So over to Dr. Prithvi. He'll be talking to us on macular subretinal fluid, always CSC, think again. So the aim of this instruction course was a lot of similar conditions come to our OPD, common conditions, and we just wanted to have a differential on what else it could be. Some diseases mimic each other, some diseases are found coexistent together. So this IC will cover that. So over to you, Dr. Prithvi.
Thank you, Dr. Shishir, for having me here. I'll be talking about macular subretinal fluid. Uh, come. Yeah. Could it always be CSC or think again? So subretinal fluid at the macula, basically it's a separation due to the outer between the outer blood retinal barrier disruption, causing choroidal hyperpermeability or accumulation in the suprachoroidal space. So basically, the first thought is always CSR. So choroidal. So it is basically a separation, like we said, outer blood retinal barrier disruption, causing choroidal hyperpermeability and accumulation of fluid over here. So what are the demography? That is typically it happens in men aged 20 to 55, associated with exogenous or endogenous corticosteroids, psychosocial stress, systemic sympathomimetic use, part of and it's a part of pachychoroid spectrum. And the mechanism which occurs here is choroidal hyperpermeability and venous congestion, causing RPE dysfunction and focal leakage, producing neurosensory detachment. So, symptom-wise, acute central blurred vision, micropsia, metamorphopsia, central scotoma could be seen, and in few cases, we can see even PEDs. So the best way of diagnosing this is with OCT. You get dome-shaped SRF, and FFA can be done. You can see ink blot and smokestack focal leaks. ICG is also a good modality for diagnosing CSR. So this is a fundus image taken from a smartphone. Basically, this is a CSR macular subretinal fluid. This is the FFA images seen over here, and this is the OCT showing the subretinal fluid. So what are the other causes of subretinal fluid? The next one is neovascular causes. It could be CNV, AMD, myopic CNV, and PCVs. So basically, it happens more in the elderly population, typically drusins and RP changes. In young, it can happen in the myopic age group. And then PCV more prevalent among the Asians and black patients, may present with the recurrent SRF and subretinal hemorrhage also. Mechanism is basically through breakthrough of neovascular membrane under RP or under neurosensory retina, leading to leakage. SRF occurs later, and then intraretinal fluid can also happen along with hemorrhage. Acute and subacute central visual distortion, metamorphopsia, and central scotoma, exactly like CSR. Examination points, you will find subretinal hemorrhage and PEDs in these kind of cases. Again, OCT, OCT angio, and FFA ICG can be taken. You can see the leakage in the FFA. Treatment goes again for anti-VEGF, but CSR we won't give anti-VEGF most of the cases. In this one, we give anti-VEGF, and you can see the regression also. So this is a image of CNV. You can see the subretinal hemorrhage over here, and you can see this subretinal fluid along with a small PED like with the hemorrhage over here. The next cause is retinal vascular leakage, mostly DME and RVOs. I'll go directly to the image. You can see over here. So this is the image of CSME, and then when we take OCT, you can see subretinal fluid, which is marked A, and intraretinal fluid also. So this is something which we won't get in the other CSC cases. And then we have the RVO. This is a macular RVO, and this also has intraretinal cystoid spaces along with subretinal fluid. So this is also can be differentiated by from CSC. Then we have inflammatory and infectious choroidopathies, VKH, multifocal choroiditis, TB, syphilis, posterior scleritis. VKH, we can see it happens mostly in the younger adults and are bilateral. So this is one differential point from CSC. And then mechanism, immune-mediated choroidal inflammation, breakdown of blood retinal barrier, and widespread SRF occurs. And you can see bilateral diminution of vision, and patient will have pain, floaters, and subacute vision loss. And you can see in the examination also antichamber cells, vitreous cells, optic disc hyperemia if the inflammation is more, and choroidal folds also. So best way of doing this is a fundus imaging with the FFA will give you a good pinpoint leaks of VKH. You can see the starry sky appearance, and OCT will show you a lot of SRF pockets. So over here, you can see over here, there are a few SRF pockets which can be seen in both eyes, and which is demonstrated in the OCT also. This is a photo of multifocal choroiditis, which can also mimic CSC. And then we have posterior scleritis. It affects all ages, sometimes associated with the systemic and autoimmune disease. Scleral inflammation occurs, and it leads to choroidal secondary effusion and SRF. Severe periocular pain will occur, and patient will have decreased vision. And this can be elicited with the B scan. You can get the T sign. That's a fluid in the tendons capsule, which can be seen very clearly. And choroidal folds can occur. SRF and often ESR and CRP are elevated, and there will be intense pain. So this is a SRF of a posterior scleritis, which also looks like CSC. So that's what we need to differentiate with using a B scan, and also patient will have pain. So that is one of the major differentiating point over here. Then we have exudative detachment from systemic vascular diseases like malignant hypertension, preeclampsia. So occurs patient with severely elevated BP, pregnant woman in preeclampsia, eclampsia, and HELP syndrome. What's the mechanism here is choroidal arteriolar ischemia, which causes RP necrosis and exudation leading to bullous bilateral serous detachment. And sudden bilateral vision loss occurs, and often with systemic signs like headache, seizures, very high BP, examination show Elsnick spots, and serious detachment. So again, investigation can be done, OCT fundus photo, and this is a SRF fluid of a high elevated blood pressure patient, hypertensive patient. And then we have structural and anatomical causes, two of them, that is optic disc pit maculopathy and Best disease. Over here you can see there is a small disc pit which can be seen over here clearly. So that could cause extravasation of fluid to the macular area. So that causes the macular SRF. So this is one cause, optic disc maculopathy. Over here you can see how it looks very prominent and looks like a CSC, but then with the disc pit over here, you can see that it is because of optic disc pit maculopathy. And this is another image of Best disease. It also has a small CSC like SRF over here, and this occurs bilateral. And then we have neoplastic and infiltrative causes like choroidal metastasis and melanoma. Go to the image. This is a choroidal metastasis, which also has SRF, but you will see a lot of choroidal bumps over here that can be differentiated. And then choroidal melanoma, again, the same kind of subretinal fluid, but there is a choroidal bump, so you always have to note this point, differentiate. And the other causes could be, when I was just talking, there are macular holes, parafoveal macular holes, which causes subretinal fluid. That can also be a differential diagnosis. Yeah, thank you.